So good morning. Today we'll be having the class on bone defects, extension of inflammation, and bone destructive pattern. So these are the learning outcomes. And these are the content. So to start with, periodontitis is always preceded by gingivitis, but not all gingivitis will progress to periodontitis. The transition of gingivitis to periodontitis is associated with changes in the composition of the plaque. So in advanced stages of a disease, that is periodontitis, you would be seeing the number of motile organisms or spirochetes increases, whereas the number of coccoid rods or the straight rods, which are the good ones, they decrease. The cellular composition of the infiltrated connective tissue also changes with increasing severity of the lesion. So coming on to the pathogenesis of any periodontal disease. So this, I think we have already seen this slide many times. So initially when you are leaving the plaque behind for 2 to 4 days, then it would result in the initial lesion where the neutrophils are predominant, and in case of if you leave it for more than 4 days to 7 days, it goes into the early lesion where the lymphocytes are predominant and you would have more of erythema and bleeding on probing seen. If it is an established lesion within 14 to 21 days, you would see more plasma cells present. So Simon from his study has told that as long as it's a contained gingivitis, you would be having the T lymphocytes. But then when it becomes progressively destructive, the lesion becomes a B lymphocyte predominant one as it goes along. So histologically, how the pathogenetic, the spread of the infection is, you would see that if plaque is present interdentally, so you can see that this is in the interdental area, there are two teeth here, and if plaque is present interdentally, then the infection spread would be there from the gingiva to the bone, or from the bone to the periodontal ligament, or from the gingiva to the periodontal ligament. And if the plaque is present on the facial and the lingual aspects, it would start its process or its destructive process from the gingiva along the outer side of the periosteum, or from the periosteum into the bone, or it could be from the gingiva into the periodontal ligament. So this is how the infection starts to spread. So this again, it is there in the pathogenesis of pocket formation. So generally, when the pocket is formed, there is inflammatory changes in the connective tissue wall of the gingival sulcus, and you would started seeing here. So the cellular and the fluid inflammatory exudate cause a degeneration of the surrounding connective tissues. So just apical to this junction epithelium, you would see that the collagen fibers which are there here gets destroyed and gets occupied by the inflammatory cells and epithelium as here. So it gets occupied by the inflammatory cells and the edema. And as the periodontal disease progresses, the collagen connective tissue fibers and the connective tissue attachment to the tooth are destroyed, and therefore the epithelial cells start to proliferate apically along the root surface. So the periodontal pocket deepens. As the junction epithelium migrates apically, so does the extent of the tissue inflammatory exudate also. So naturally it reaches the bone also there. So the activated osteoclasts in and around initiate the bone destruction. So this activation of osteoclast is mediated by two main categories. One is the activation of the rankle, rank, and OPG, which are the three noble members of the TNF ligand and receptor superfamilies. Rankle is otherwise known as the receptor activation of nuclear kappa ligand. So these are all bigger terms which you will lead only if you do PG in perio. So just understand that activation of osteoclast takes place with the help of these three members, or by the help of hormones and cytokines which modulate the o- osteoclastogenesis, which is formation of osteoclast by enhancing the osteoclast differentiation, activation, lifespan, and function. So coming on to the periodontal bone architecture, your general periodontal bone architecture is one in which it is just 1 mm below your CEJ line and increases with age up to 2.8 mm. So the bone contour also follows the contour of the overlying gingiva. So coming on to the radius of action, so there were several authors who gave what is the radius of action till when what occurs, how does this bone loss occurs. So whenever there are any locally produced bone resorption factor, for example, calculus, if it is present in proximity to the bone surface, then it is easier to exert the action. So Page and Schroeder also found out that found out if there is a range of effectiveness, that is, if plaque is present, around how much range that it is effective, that it will result in bone loss. So its range of effectiveness is around 1.5 to 2.5 within which the bacterial plaque can induce bone loss. So beyond that, there is no effect. But interproximally, since they are narrow, even in interangular defects can appear in spaces wider than 2.5 also, because narrower spaces are more easier to destroy. Larger defects greater than 2.5 and if you find there's going to be any destructive activity there, it is because of the tissues present in the it is because of the bacteria present in the tissue that the uh, bone loss is taking place. So this is about the radius of action. Coming out of the rate of bone loss, so this was a study done by Lowe in 1986 on the Sri Lankan tea plantation workers, where he stopped them having oral hygiene and no dental care, and he for around period of 21 days, and he noticed how the gingivitis is proceeding. Then he started asked them to again carry on with their oral hygiene techniques. So from this, he found out that the facial surfaces per year underwent a resorption of around 0.2 of the bone, whereas proximal surface 0.3 per year. So this is actually very minimal. But then when he was able to categorize the patient based on interproximal loss of attachment and tooth loss, he found that there were rapid loss of bone in certain people, like around 8 percentage of them, moderate loss in certain people, 81 percentage of them, and minimal loss. So we all might go into this moderate category. So all of us would have some amount of bone loss present in our oral cavity, which would be taking place little by little as the age goes. So coming on to the periods of destruction, this periods of destruction and construction is always a balance. So when there is periods of destruction, there is going to be it's going to be a stage where there is going to be excessive destruction of the bone. So this occurs in episodic intermittent manner with periods of inactivity or quiescence, and destructive periods that results in loss of collagen and alveolar bone and deepening of periodontal pocket. So followed by this, you have the period of quiescence or there is no destruction. So there's always a cycle. Once the destruction occurs, the body tries to manage its destruction, and again during this managing of this destructive activity, there will be no destruction taking place. So it is inactive or quiescent in that phase. So four theories for the onset of the destructive period. How does this destructive period gets switched on? So one is the burst of the destructive activities associated with the subgingival ulceration and an acute inflammatory reaction, or it could coincide with the conversion of predominant T lymphocyte to B lymphocytes phase. As I told you previously, that during the gingivitis, it's going to be a contained T lymphocyte phase, whereas when it goes to advanced stages, it goes to the B lymphocyte stage. Next is periods of exacerbation are associated with increased gram-negative anaerobic flora, whereas periods of remission you have good bacteria, gram-positive flora is present. And another thing is tissue invasion by one or several bacterial species is followed by advanced local host defenses that controls the attack. So that's why you're having a period of quiescence, because advanced local host defenses control the attack there, right? Now, factors determining the bone morphology in periodontal disease, you have such a lot, we'll go one by one. So, a normal variation in alveolar bone, considerable normal variation exists in the morphologic features of alveolar bone, which affects the osseous contours produced by the disease. Generally, the thickness of your thickness, width, and the crustal angulation of your interdental septa will define how your disease is progressing. So, supposing normally itself you are having a slight amount of angle in your uh, bone, then if the periodontal disease is going to onset, then it's going to go at a rapid phase. Then the thickness of the facial, lingual, or the alveolar bone plates. You would have heard of the term fenestration and dehiscences, where the labial plates are becoming thin. So this is little difficult to manage, because as such morphologically itself they are deficient of bone there. Then about the alignment of the teeth. If the teeth are like too much protruded, then again your facial or lingual place would not be there. Root and trunk morphology, anatomy, like for example, if the root trunk is more in case of a molar teeth, you would obviously, less in case of a molar teeth, you would obviously get defecation involvement very soon. Root position within the alveolar process and proximity with the another tooth surface are the factors which determine normal variations in the alveolar bone. Next, coming on to exostosis. So these are outgrowths of bone, small or large nodules, sharp ridges which are present. So I think we ourselves have done a study regarding exostosis. Coming on to buttressing bone formation. So, bone formation sometimes occurs in an attempt to buttress the bony trabeculae weakened by resorption. When it occurs within the jaw, it is called a central buttressing bone formation, wherein the endosteal cells deposit the bone and restores the bony trabeculae, reduces the size of the bone marrow spaces. When it occurs in the external surface, it is termed as peripheral buttressing bone formation, otherwise known as lipping, where there is bulging of the bone contour, sometimes accompanied by the production of osseous craters and angular defects. Coming on to food impaction, this also results in bone defects because food is often getting lodged in one particular area. So interdental bone defects often occur on the where proximal contact areas abnormal or absent. Pressure and irritation from food impaction can contribute to inverted bone architecture. Aggressive periodontitis, so this term is now not used much now. So here you will be having a vertical or angular pattern of alveolar bone destruction around the first molars. This is mostly localized again near the first molars or the incisors. The cause is unknown. Coming on to trauma from occlusion, I think we had the last class on this. So here, when the occlusal forces exceeds the adaptive capacity of the tissues, there is a tissue injury occurring, and this injury is termed as trauma from occlusion. So trauma from occlusion may be a factor in determining the dimension and the shape of the bone deformities. It may cause thickening of the cervical margin of alveolar bone or change in the bone morphology on which inflammatory changes may later be superimposed. Coming on to the patterns of bone destruction. So you do have different patterns, and according to their names, you can see that there is a kind of bone loss according to their names. Starting with horizontal bone loss. So here horizontal bone loss means you will be having a reduction in your bone height. So here you can see that the bone height where the bone height is reduced, but the bone margin remains perpendicular to the long axis of the teeth. So this is called as horizontal bone loss. Supposing if it is in an angulated manner or in an oblique direction to the long axis of the teeth, it's called as a vertical or angular defect. It leaves a hollowed out trough-like effect alongside the root, and the base of the defect is located apical to the surrounding bone. So this is called as a vertical or an angular effect. So classification of osseous defects, it could be osseous defects such as suprabony or infrabony pockets, interradicular defects. So infrabony pockets have been further classified as one wall, two wall, three wall combination of the craters. So we will see what it is. Interradicular defects, again, this is kind of a furcation involvement, otherwise known as interradicular defects. So starting with the classification of the infrabony defects. So infrabony defects, one wall defect is one in which the defects are limited by only one wall at one side. Supposing if you see this particular teeth, it will be always having three walls around it. So this is your tooth surface. So normally you would be seeing a distal wall, you will be seeing a buccal wall and a lingual wall. Whereas in case of a one wall defect, only one wall is present, which means the buccal and the lingual wall is gone, right? Next, coming on to the intrabony defect. Again, if it is two wall intrabony defects, which means that only two walls are present. So defects are limited only by two osseous walls. So here you can see that the buccal and the palatal wall, the distal and the palatal wall is present. The buccal wall is missing. Here also you can see that the distal and the palatal wall being present. So again, three wall defects means defects lined by three osseous defects, and you have a trough-like effect here. So this is called as a three wall defect. Combined defect, so it combines all the three. It could be either in the top it could be an two wall defect, one wall defect, and in the bottom you would have had a one wall defect or a three wall defect. So that's called as a combined defect. So coming on to osseous craters, this is defined as a cup or a bowl-shaped defect in the interdental bone area, with bone loss nearly equal on the roots of the contiguous teeth or more coronal portion of buccal and lingual alveolar bone. In other words, it's a cup or a bowl-shaped defect which is present with more bone on the on the buccal and the lingual and lesser bone in the interradicular area. This defect can be considered as a result of apical spread of periodontitis and along the two adjacent roots in a relatively narrow interdental area. This interdental area could collect plaque and it's more difficult to clean. So normal or even flat uh, concave facial lingual shape of the interdental septum in lower molars may favor crater formation. Coming on to ramp, in its purest form, the term ramp describes the deformity that results when the alveolar bone when the alveolar bone and its supporting bone are lost to different degrees, like for example, this is your supporting bone and this is your alveolar bone. So it is lost to different degrees. So you have a ramp-like effect here. So the term as so it is termed as ramp. Whereas when your alveolar bone and your supporting bone is lost to somewhat the same level, then it is called as a plane. So it can be considered as horizontal bone loss about one teeth or a portion of teeth. Now, coming on to the reversed architecture, these are defects produced by the loss of the interdental bone, including the facial and the lingual bone plates, without concomitant loss of radicular bone, thereby reversing the normal architecture. So, in other words, this could be an effect where normally you would see that the interdental bone is higher and the radicular bone, that is the buccal and the lingual bones, are somewhat in lower plane. So, this will be like a U-shaped fashion. Whereas in case of a flat architecture, you would see that all three becomes on a straight line. Whereas in case of a reversed architecture, you would see that the interdental bone becomes much lower than that of your facial or the lingual bone. So this is called as a reversed architecture. Hemiseptum is another term for one wall defect. So remaining half of an interdental septum is called as hemiseptum. Next is ledges are plateau-like defects which are caused by resorption of the thickening bone, and bulbous bony contours could be present in the case of exostosis, adaptation to function or buttressing bone formation. Suffocation, according to Glickman, it is the invasion of the trifurcation or bifurcation of a multi-rooted tooth. So basically, please understand, furcation will be present only in case of a multi-rooted tooth. Okay, so grade 1 furcation is one in which there is an incipient or early lesion of furcation involvement, and grade 2 is one in which affects one or more teeth of the same tooth. So furcations of the same tooth. It's definitely it is otherwise cul-de-sac effect with a definitive horizontal component. Basically, if you insert a probe from this area, it doesn't come out through the other area, so it is contained to one side. So this is called as grade 2. Grade 4, here there is also gingival recession present, where you can see grade 3 very easily with your open eyes. So this is your grade 4 furcation involved. So, according to Hamp in 1983, he modified a three-stage classification system by attaching the in measurement to separate the extent of horizontal involvement. Class 1 is one in which there is less than 3 of horizontal attachment loss, and class 2 is one in which the horizontal attachment loss is 3 but not through and through. Class 3 is one in which there is a through and through horizontal attachment loss. Tarnow has classified the same with the vertical attachment loss, where furcation involvement with bone loss is present, 3 or less, 3 to 6 and then 7 and more. So these are subclass A, B, and C. So to conclude, the amplification and the propagation of inflammatory response through the gingival tissues is critical to pathogenesis of periodontitis. However, it is the spread of the response to areas adjacent to the alveolar bone that drives the cellular machinery involved in the bone loss. Deciding on a diagnosis has several practical purposes. It sets the stage and context for treatment planning, helps in estimating the outcomes, and facilitating the communication with colleagues and patients.